Hey everybody, today we're going to talk about the concept of elimination and focus on the exemplar of BPH. The objectives of this session, we're going to talk about BPH and how it relates to elimination. We're going to talk about patho, etiology, risk factors, prevention, definitely discuss the clinical manifestations, diagnostic tests, things we need to do as nurses with our collaborative care for clients, and then we'll talk briefly about the nursing process. So BPH is benign prostatic hyperplasia. This is non-malignant enlargement of the prostate, and it's very common in aging men. And it's the most common benign neoplasm in men. I want you to remember that BPH can cause anxiety related to fear for some of our clients. So a lot of what we're going to do as nurses is going to be patient education so that we can kind of decrease that fear and also dispel any myths. From a patho side, I want you to take a look at the graphic and note that nodules will be formed from hyperplasia, and that means there's an increase in the number of cells. And they're not formed from hypertrophy, which is an increased size of individual cells. Now, sometimes those words get used interchangeably, so when you hear them, it's just one is one and one is the other, but you just might hear them used back and forth. And this is going to occur over a long time. So if you look at the picture, you can kind of see how a lot of those cells are growing there in that prostate tissue, and they're starting to restrict or narrow the urethra. So for etiology or cause, we did talk that this happens in aging male population. Basically, this increase in the number of cells that form in the prostate, it's done by a lot of hormones that play a role with male traits. So for example, you have testosterone. Now testosterone is going to stimulate the production of what's called dihydrotestosterone or DHT, and this is going to mediate prostatic growth. Also know that the aging prostate is more sensitive to available DHT. Some other things, an increase in estrogen level, this can contribute to BPH as well. So we're looking at risk factors. Age is important for this particular diagnoses, as well as the presence of testosterone. BPH is rare for male individuals before age 40, but 50% of men in their 60s are going to have manifestations. And then up to 90% of men over the age of 80 will develop BPH. Racial background does have an effect. So for example, Black and Hispanic men may develop symptoms earlier, and Asian men may develop symptoms later on. There's no known prevention, but there's a connection based on some new evidence between BPH and metabolic syndrome. So when you're thinking about maybe some preventive aspects based on this new evidence, what do we do for diabetes and metabolism? We want them to have a healthy lifestyle, keep our body weight within recommended ranges, exercise daily, and of course, a proper diet to control blood glucose levels. So the manifestations that your clients are going to say to you or that you may see on your assessment, it's coming from the urethra being compressed because of that mass of cells. Remember the little picture we saw before. So this could be a partial or complete obstruction or compression. This may increase resistance to urinary flow, decrease bladder capability, and cause bladder instability. Now, typically what you'll see are symptoms of voiding or symptoms of storage. So for voiding, clients may comment or you may see a weak urine stream, increased time it takes to void, hesitancy with urination, incomplete bladder emptying, and post-void dribbling. If storage is effective, that's when we'll see frequency, urgency, incontinence, nocturia, urination at nighttime, and bladder pain. Now, urinary retention may become chronic, and this could cause overflow incontinence or increased intra-abdominal pressure. This can cause some complications if that mass isn't reduced and that pressure taken off. The bladder can become distended. Infections can be more common because urine is being retained. Even that the urine and possible infections, they can go from the bladder and ascend up into the kidneys. Also, some other complications may be hydroureter or hydronephrosis. As always, we want to collaborate as nurses with the healthcare team and our patients, but we do want to focus on getting the disorder diagnosed and correcting or minimizing any urinary obstructions, as well as preventing or treating any complications that may arise. A lot of times, mild cases of BPH, they're going to remain stable and they may improve over time. So there's a lot of diagnostic tests that we can do. I want to focus on the starred ones today because these are really important when we're talking about BPH. So the primary diagnostic test is going to be a digital rectal exam. This is most common, and it's going to be able to feel, the provider is going to be able to feel for enlargement of the prostate. Another important test is going to be a PSA test. This is not to diagnose BPH, but this is going to be done to rule out prostate cancer. And then a cystoscopy, this is going to look at the bladder and the urethra, and this is going to rule out any other causes or potentially see obstructions. Now, they may do urine flow rate tests, post-void residuals, just to kind of get a better idea of what's going on with the urinary system, pressure flow studies as well, and then a urinalysis and a culture, especially to diagnose if there's any infectious process. So there's a lot of surgeries that can be done to help with BPH. I want to focus on one, and it's called a TURP, transurethral resection of the prostate, and this is used most often. This is done to remove the obstructing prostate tissue, the one that's like kind of restricting the urethra there. Now, this does have some potential complications. Um, it may cause hemorrhage, clot retention, inability to void, or possible UTIs. What we need to remember about a TURP, just in a general sense for right now, is that prior to surgery, you do need to do education. They're going to take a device up through the urethra and they're going to actually try to cut away that extra tissue. So this is an invasive procedure that requires a consent. Um, After the surgical procedure, clients are going to be they're going to be on continuous bladder irrigation or CBI. What that is, if you can envision it, is a three-way Foley system. You're going to have a 3,000 milliliter bag of normal saline, and it's going to be infusing into the bladder and throughout the urethra in a Foley drainage system. So that's going to help catch any clots and keep the urine moving so that as everything is healing, there won't be any complications. While a client is on CBI, we need to make sure that we're doing strict hourly assessments, intakes and outputs, very strict, as well as titrating that fluid so that the drainage that's coming into the catheter bag is a pink color. We also need to be mindful we're infusing a very large amount of fluid into the bladder system and out of the body, so clients could develop what's called TERP syndrome. And this is where they can get hyponatremia and fluid volume excess. You know, as always, I got to bring a pharm slide into anything I do. So let's just talk about two different classifications that you'll see. One is going to be the 5-alpha reductase inhibitors. Um, you may see this as Proscar. This works by inhibiting the conversion of testosterone to DHT. Remember, we talked about that. It was kind of back in the patho area. Um, it's going to ultimately decrease the prostate size and then decrease serum PSA levels. Now, there are some side effects with these particular medications. They can cause impotence, decrease libido, and decrease ejaculate volume. Again, also, that could lead itself into potentiating anxiety, fear, or any other psychosocial aspects related to BPH and the treatment of. Another very common medication is going to be the alpha adrenergic blockers. One very common is called Flomax. Now, this is the first line treatment for symptoms, and this is going to work by relaxing muscles in the bladder neck and the prostate to relieve obstruction and increase urine flow. We want to be very, very mindful with Flomax and watch for hypotension. As always, you do want to be mindful of over-the-counters and herbals. I think we talk about this a lot all the time. Um, Things like pseudoephedrine, they can restrict urine flow. Antihistamines, these can have an anticholinergic side effect that can affect BPH, and steroids may increase prostate enlargement. Now, non-pharmacologically, we touched on this a little bit before. Some other things that we can do to kind of help our clients is make sure we're teaching them to urinate at their first urge and not to hold their urine. As always, avoid alcohol and caffeine. We want them to drink small amounts of fluids spread throughout the day, and then avoid drinking fluids within 2 hours of bedtime so that it will help with any night urination. Um, Again, avoid over-the-counter cold and sinus medications, exercise regularly, and try to reduce stress. So we're considering the nursing process. So we're going to take it from beginning to end for our clients. We definitely want to assess and gather data. So we want to ask them about their risk factors, definitely their elimination patterns, any symptoms that they're experiencing. Always ask to see if there's any blood in the urine or collect urine to do so, and ask about pain. When we're thinking of a few other things on assessment, we want to make sure that we're doing a urinalysis. We do want to look at white blood cells, red blood cells, and bacteria to monitor for infection, and also get a serum PSA level if the doctor has not ordered it. Common nursing diagnoses that you may see for these clients: urinary elimination impairment, ineffective sexuality pattern, risk for infection are just to name a few. We do want our client to we want to establish some goals with them. So basically what we want to do is we want to try to help them get to a point where they do not have the manifestations anymore and that they are reduced. Also, if your client is going to have a TERP, you want to make sure that you educate them, provide support, make sure you talk about what's going to happen after surgery, and then also help them deal with any anxiety that may come. Again, post-operatively, very important. We need to make sure that we're monitoring their vital signs frequently per policy. Also, if they're on continuous bladder irrigation, again, every hour you need to be going in there and documenting and assessing the color of that urine, looking for clots, making sure what's going in is what's going out. If the client has any pain, of course, assess and manage that. And we want them to try to encourage fluids, um, try to tell them not to strain, especially if they're having the catheter. They may have bladder spasms, and we may want to medicate with that, and always just keep monitoring for any bleeding post-operatively. On evaluation, we just want to make sure that if the client has any pain, that it's controlled. We want the client to get to a normal continent function. So lots of teaching. We really need to talk about realistically how long this may take, and make sure that the client, even after any treatment or medication, especially for BPH, that they follow up with their provider. All right, so if you have any questions about BPH, please make sure you post those in the Prep for Exam 3 discussion forum of your Blackboard course.